Good morning.
Are we going to be doing a lab?
The heart. Next week, we're going to have the actual hearts to dissect. This week, we're going to look at the models. So be prepared to get messy next week.
Elearn still says that our lab test is due.
Yeah, I haven't even set it up yet. Don't worry about it.
So just ignore it.
Ignore that. Yes.
That's what I thought. Just wanted to make sure.
Yeah. Just leave it like this. Okay, let's go ahead and get started. We are still in repro, and let's see if I can get us into the right topic area. I think we had just stopped. We were been talking about the uterus. See if that's going to work for us, and I think it will. Okay. The uterus, female reproductive structure. We have a body, a fundus, and an isthmus in there. The body is the middle portion of the uterus. The fundus is the curve, and the isthmus is the area that leads down to the cervix. It looks very much like a pear, an inverted pear. You know, it's a large body, large fundus curved at the top and narrowing down to the neck. About the size and shape of a pear also. The cervix is at the end of the uterus. It connects it to the vagina. The cervix helps to protect the uterus. It generates mucus, which will plug the cervical canal so that bacteria and pathogens and material can enter the uterus from the outside. Because remember, the reproductive tract is open to the outside. The vaginal orifice leads into the vagina, which leads into the cervix, which leads into the uterus, which leads into the uterine tubes, and leads into the abdominal cavity. So we are wide open in there for anything to pass through. But the cervical canal, which you see in the right-hand side here, is filled with mucus. And that plug keeps things out. The only time that mucus plug thins out is right around the middle of the uterine cycle, right around the 14th day. in anticipation perhaps of the presence of sperm and semen. This is the opening into the uterus, looking at it from the perspective of the entrance, actually the cervical canal. You're looking at that structure right there. What you see there is this canal in here. Now the cervix has some issues of its own. Cervical cancer is, it is a significant cancer. You can see the numbers there, almost 500,000 women killed every year. It is one of those cancers that isn't readily obvious until it's usually pretty far along. It's hard to catch it. It's easy to ignore, is what I'm saying. Risk factors. If there are inflammatory conditions in the cervix, if the cervix is exposed to pathogens, for example, a person that has numerous sexually transmitted diseases may be at risk for cervical cancer. Human papillomavirus is the virus that causes various types of cervical cancers, because there are cancers that are triggered by viruses. An individual that has multiple pregnancies is at a greater risk. And an individual who has multiple sex partners is at a greater risk. So the treatment, the preventative treatment for cervical cancer is Gardasil. It is a vaccine. It comes in, you have to have 3 doses. It's like the hepatitis B vaccine. It comes in was it 3 months apart over a 6-month period or something like that. Generally, as your female patient starts puberty, she gets this injection of Gardasil, and that prevents the virus, it creates antibodies to the virus, essentially. Now, how do you detect cervical cancer? Well, the method of choice that's been around for a long, long time is the Pap smear. The Pap smear simply involves taking tissue samples from the cervix and examining them to see if any of them have become malignant. It's like one of the advantages of the cervical cancer is that it is a slow grower. So you can see here, you would have a Pap smear every 3 years between the ages of 21 and 30, and every 5 years between 30 and 65. And after 65, you can stop if your patient's had a hysterectomy or if there is no sexual activity going on. However, we'll see later on in this chapter that sexual activity does not tend to shut down at 65. We find that the greatest number of sexually transmitted diseases and infection, the greatest number of cases are occurring in, anybody want to guess?
Older women.
Older women and older men too. Apparently nursing homes and not hospice, but nursing homes and retirement centers are the epicenter of some significant infections, and we'll talk about that. So don't discount that when you're talking with an older patient, and don't be surprised if you discover that they've got this funny sore that you have to look at, because just because a person's over 65 doesn't mean that they're not sexually active. So this may alter the thinking about, Pap smears. Okay, now cervical cancer. You have to examine the cervix with get a Pap smear. As I said, it's a slow grower, but it will kill your patient if it's not caught in time. This is what the Pap smear looks like. You take a speculum and place it in the vagina. That opens up the vagina so that you can reach the cervix, and then you take a little special type of spatula to scrape skin cells away. a little more sophisticated than using a toothpick like we do in AP1 lab, yes.
So I've had one for a reason I'm not going to discuss, but
Okay.
what always makes me laugh, like when I hear people talk about these, is in my, like when I had mine, like my doctor was like, it's not going to hurt. I was like, okay. And, you know, I tried to relax, but that kind of thing's hard, you know, like, but, and she warned me when she was doing it, but it hurt so bad. And she ended up not being able to do what she needed to be able, like what she needed to do because I couldn't stand it. And I'm like, why would you tell me it's not gonna hurt?
Mm-hmm.
You know, it just, I'm like, why is that a thing that doctors do? It just doesn't make sense.
It's like biopsies. They say, it's not going to hurt. You know, we've given you something. It's not going to hurt. And they hurt.
Yeah.
You know, so yes, I can agree with you there, definitely. Because you know you are scraping away tissue, and depending on how enthusiastic the scraper is, you know it may hurt, like in your case. So, but this is what we look for. This is the cervix. We're looking for abnormal growth of cells. That's the characteristic definer of cancer. You see on the right side of the screen where it says normal epithelium, you can see that looks like probably simple columnar cells and with lots of goblet cells in there because you have to have mucus. But over here where we see this uncontrolled growth, because remember, cancer cells don't have contact inhibition, so they grow over top of each other. They don't grow in defined shapes. They can be large, they can be small, they have no consistency. So you can look at that and say, well, it's supposed to look like the normal epithelium, but it doesn't. You notice it also is probably 3 or 4 times thicker than the normal epithelial cells are. So again, I'm not a pathologist, but I think we can all look at that and say, well, that doesn't look right. So it's just something else to consider when you're dealing with your female patients. It's always a concern. So, and because the thing about it is, if it isn't caught, it will spread. Here we see a cervical cancer. It started in the cervix and has now spread. All these dark spots here represent where it has metastasized, where it has spread to the base of the neck, to the left axillary region, in the mediastinum, in the middle of the chest. It's above the clavicle, you know, on the left-hand side. All those dark spots are tumors growing in that individual, in addition to growth down here in the pelvis and the inguinal regions, you know, and below the ureters and stuff like that. Now, normally when we look at a PET scan, we tend to ignore the ureters and the bladder and the kidneys because that's where, you know, the dye goes, and we look for everything else. But here we can see it has spread everywhere. You know, this individual is in a world of hurt as far as whether she's going to recover from the cancer or not. So, okay, the uterus now held together, but held in place by a series of ligaments. You know, you have the uterus is held to the sacrum. It is held to the front wall of the abdominal cavity. It's held to the lateral walls of the abdominal cavity by these ligaments. The uterus itself is made up of 3 layers. It has the outer layer called the perimetrium, the middle layer. The outer layer is the visceral peritoneum. If you remember, you have parietal and visceral layers when you're dealing with serous membranes, and the visceral layer is the surface on the is the layer that's on the organ. So we have the perimetrium. Underneath that, we have the myometrium, which is layers of smooth muscle. This is where we get our contractions during childbirth. And then we have the endometrium, at the innermost layer of the uterus. Now, the endometrium is a mucus layer, not a serous layer, because the the inside of the uterus is exposed to the outside, so you're going to have epithelial cells. Now, the endometrium has two layers to it. It has what's known as stratum basalis, which is its basement layer, and it has the stratum functionalis, which is the layer that sloughs off during menstruation. The stratum functionalis builds up every cycle from the stratum basalis, and once the stratum, the functional layer, is engorged with blood and enriched, somewhere after day 14, because you have a fertilized egg will come down by day 21 and try and implant itself in the functional layer, in the stratum functionalis. And if there's no egg and no implantation, then, or if there's no implantation, even if there is an egg, or the egg isn't fertilized, it doesn't matter. If there's no implantation, the functional layer will slide off. That's what causes menstrual flow. That's the functional layer coming off. And there's still no guarantee that that's not going to happen if there's a fertilized egg, because we don't know if the egg's fertilized or not. A fertilized egg may come down there and fail to implant. It can happen. Okay, now, so this is what the lining of the uterus looks like. There is from the, we don't see here's the lumen up here at the top of the picture. So this is the open portion of the uterus. This first layer here moving towards the, away from the lumen, this is the stratum functionalis. This is the layer that becomes enriched with blood vessels and glands. This is the one that becomes engorged with blood and gets thicker to allow implantation of the fertilized egg. Below that, we have the stratum basalis, which is this area down in here. And then below that, we have the smooth muscle. The perimetrium would be down here somewhere in the way this is laid out. It's sort of reverse to how you're looking at it sort of backwards. The lumen's at the top, stratum functionalis, stratum basalis, smooth muscle, and then the perimetrium would be down to bottom. It is the stratum functionalis that slides off on days 1 through 5 of the uterine cycle and is rebuilt back up. Yes.
I don't want to interrupt, but it looks like you might have a chat.
Oh, thank you. Thank you. Yes. Well, we need, maybe, probably not. But you should know that the stratum functionalis is the layer that does slide off. It is the layer that receives the fertilized egg, if there's a fertilized egg present. So this is a layer that builds up. You may not, I don't like to put a lot of diagrams on tests sometimes, but I will say that make sure you know the difference between the stratum functionalis and the stratum basalis. So good question. Thank you for catching that for me. So, okay. The functional layer, the stratum functionalis, is rebuilt starting about day 5 of the uterine cycle. And it will reach its maximum just about day 21, because it will continue to build up, because day 21 is when the egg is usually going to arrive at the uterus. Now, if nothing happens, it will break down at the end of day 28. So you've got a week. You got a fertilized egg has 7 days. It usually ovulation occurs on day 14, and we have 7 days to get to the uterus. And then we have 7 more days to get it implanted and start producing the pregnancy hormone, which is escaping my mind right now, that triggers it, allows the presence of progesterone to keep occurring. So HCG, human chorionic gonadotropin. HCG is what the placenta produce, I mean, not the placenta, but the uterine, the stratum functionalis produces so that the corpus luteum will continue to produce progesterone and keep the lining of the uterus intact. It is progesterone, the constant release of progesterone from the corpus luteum, that keeps that lining in place. Okay, now, and there's again showing essentially a real picture of what we were just talking about with the lumen, the stratum functionalis, the stratum basalis, and the smooth muscle layers. A lot of blood going into the uterus. Not a lot of blood is lost during menstrual flow. You lose more tissue. Your female patient loses more tissue than anything else. The amount of blood lost is just a few milliliters of blood because these vessels are being pinched off, but there's a lot of tissue that slides out, which of course is red. So it looks like there's a lot of blood leaving here. The blood supply comes up out of the stratum basalis, and we see these come from the arteries which are supplying the uterus itself, coming up from the parametrial layer. And we can see that what will happen is that these straight arteries in the stratum basalis, the basement layer, will give rise to these spiral arteries that occur in the stratum functionalis. And see what is going on here is we have a connection between the arteries, the arterioles, and the venules. Here you can see where we go from red to blue. And so we create these sinuses in there that allow a collection of blood supply. See, we'll get into all this on what happens in utero with the baby and the placenta, but we keep this highly vascularized region here with lots of blood flowing through here. Well, if we don't have implantation, then the straight arteries start pinching off at the layer of the basalis, in the stratum basalis underneath the functional layer. And so they'll pinch off, and gradually those arterioles up in the stratum functionalis will rupture. And then all that, those epithelial cells that have formed are all going to slide out. And that's what menstrual flow is. It's mostly tissue. So, okay, problems with the uterus. Uterine prolapse. Uterine prolapse, the uterus can actually slide out through the vagina. During an abortion, the uterus is always tilted over top of the bladder. It makes a 45-degree bend over top of the bladder. And the person who's having an abortion and the abortionist doesn't know what they're doing, very easily can cut into the abdominal wall or the vagina. And of course, that can lead to death. Endometriosis. Growth of endometrial tissue outside the uterus. Ectopic pregnancy can occur. The baby can never make it to the uterus. It starts to grow in the uterine tube. Pelvic inflammatory disease. This is inflammation of the pelvis through constant irritation, and we have a tilted uterus too. So let's take a look at some of this stuff. This is prolapsed uterus. We see this a lot in elderly patients. The ligaments that hold the uterus in place may become stretched and relaxed. And what will happen is the uterus, instead of being tilted over top of the urinary bladder, can be tilted backwards. And if there's enough stretch and play in those ligaments, the uterus can slide through the vaginal orifice and present itself to the outside. Yeah. these are examples of what can happen with a prolapsed uterus. It can slide through the vagina, and the opening at the cervix can now protrude through the vaginal orifice. And it happens. It happens, I don't want to say frequently, but it does happen, particularly in your elderly patients. It happens in females that have had lots of babies, because all those babies are going to stretch those ligaments, and it looks something like this. What you're seeing protruding, you can very clearly see the labia on the picture on the left. You can see that the labia on either side of this structure. That's the uterus. The opening is the cervix. The same thing is happening over on the right-hand side too. About 10 years ago, I had two students that were in AP2, and they were working at one of the local nursing homes, and they came in and said that they were supposed to start a catheter, a Foley catheter, a urinary catheter on an elderly female patient. And when they went to do it, they discovered that they couldn't find the urethral opening because her uterus had projected through it, prolapsed through. And generally you have to push it back up and reattach it. So there is a certain amount of surgical intervention involved here. It doesn't happen often, but it does happen. So it's something just to be aware of that you may encounter. Now, endometriosis. This occurs when the endometrial lining of the uterus, when it's sliding off, when some of the cells decide to go backwards. And instead of sliding out through the cervix and the vagina, they migrate out the fallopian tubes, and they find a place to live out there in the fallopian tube or even in the abdominal cavity. And they often will grow around the ovaries. They may grow anywhere in the abdominal cavity on any of the surfaces, and they will go through their 28-day cycle out there in the abdominal cavity. And they will grow and create scar tissue, and then they will bleed off, and then they'll grow new tissue, and they will continue to grow. In some cases, they'll grow over top the ovaries. On this uterus that you're seeing here, on the left-hand side, that red mass is endometrial growth that surrounds one of the ovaries there. And the same thing is occurring to a lesser extent on the right. The problem is that when an egg is released, the egg can't find its way into the uterine tube. And even if it did, the uterine tube is likely blocked. And so no sperm can do anything with that either, because sperm can't get to the egg. So we don't know why the endometrial cells decide to migrate backwards. As they say, retroperitoneal, they go backwards in here. These endometrial cells from the stratum functionalis will grow over top of the large intestine, the small intestine, the ovaries, anywhere in the abdominal wall in here, and they will continue to run through their 28-day cycle. And then they form scar tissue. They also may form cysts. And what will happen is that endometriosis becomes the #1 cause of infertility, because it is going to block access to the ovaries. The ovaries, if they release an egg, it gets trapped by the scar tissue. If the egg can't get into the fallopian tube, sperm can't travel up the fallopian tube because it's blocked by the scar tissue. And you can see there's a whole lot of places. There are numerous locations in the abdominal cavity where scar tissue and growth can take place. It is, there's no reason for it. We don't know why it happens. There may be a familial connection here where if you have, if your sister or your mother or your cousin has endometriosis and you develop endometriosis, there may be some sort of genetic component to it. It is, some females in a family are predisposed to endometriosis. Not everybody's going to have endometriosis, but many do. And it's hard to treat. It's very hard to treat, and it often involves laparoscopic surgery to remove scar tissue. You may involve removing one ovary or even both ovaries, because one of the consequences of endometriosis is very painful, excruciatingly painful periods. Your female patient will have severe cramps and fever and a lot of body ache and pain for 3 or 4 or 5 days with a lot of flow. And then, and it will lead up this, then it'll get better, and then it'll start over again, on the first day of the next cycle. So it is extremely uncomfortable. And so again, it usually leads to infertility. Yes.
So I was one of the women who, when I first started my cycle, I was 9. And I actually started before my older sister, which was crazy because I had no idea what was happening, because she was older, she was prepared, and I wasn't. But anyway, for a while they thought, like, my mom, she's a nurse, but my doctor actually thought that I might have endometriosis, because when I, like, my very first cycle, it was very painful, but it lasted for 13 weeks, like nonstop, 13 weeks. And I'm talking like heaviest flow day for 13 weeks. Straight.
Wow.
And they didn't know what was wrong, because I was 9, and
yeah,
actually by the time it stopped, I was 10, because I started like a month maybe before my birthday. But I weighed like maybe 90 pounds, and they were like, why is she still bleeding? So endometriosis was a possibility, but they ended up ruling it out after it stopped, because my periods after that were a little bit painful, but then I got on birth control and whatever. But it was weird, because it was the worst 13 weeks of my life.
Oh, I bet. Yeah. And birth control pills are, that's a great way to treat any kind of irregularities like this. My niece went on birth control pills because she was having irregular periods that were very painful, whatever. I just got situated, so I'm not going to get off. My niece is on birth control pills because the issue with irregular flows, painful flows, and stuff like that, and it helped to regulate a lot of it, because you're dealing with, birth control pills contain estrogen and progesterone, which your body is normally releasing anyway. So, it does help a lot. So on that, it just, and I think 13 weeks is pretty impressive. Not in a good way, but but I think also as you got older too, your body may have gotten used to it a little bit, and started producing more estrogen and progesterone. Plus, birth control pill use helps too.
Yeah, because after that initial 13-week cycle, my period after that my period was always irregular until I got on birth control, which is why I got on it. But before I started taking the birth control, it never lasted that long after that. It only lasted like a week, maybe 2, if that. But I was on it from, I don't know, I'm 20 now, so I think I started at 11 or 12, because my cycles were really irregular. And I actually just recently got off of it because I was I'm tired, because it just made me feel it didn't make me feel good. As someone who's recovering from an eating disorder, it made me feel bloated all the time. I was like, this is not good for my mental health, so I got off of it. But and I'm relearning, my body is relearning how to regulate for itself. But yeah.
Well, one of the things we discover is that there is, it's hard to say what is normal. There's so many variabilities on what is normal on the outside, on the whole range of a normal response to something. So we talk about, on the 14th day you ovulate, and then 14 days later you have your period, and it just sounds very cut and dry. But your patient that does everything exactly right is going to be unusual. or they're the anomaly. Everybody else has got some variability. So this is what it looks like internally. Here we're looking at the adhesions and the scar tissue that endometriosis causes by the growth of, tissue builds up, breaks down, tissue builds up and breaks down. And so we get scarring forming here and we get adhesions, and these organs tend to grow together. They stick together because of the adhesions. And so you have your large intestine and your small intestine becoming twisted. You may twist the uterus around. You may twist the ovaries around. You can twist, you can grow on the kidneys and the ureters. So you can spread throughout the abdominal cavity in here. So there are some real long-term concerns about this. Another thing that can happen is the ectopic pregnancy. Ectopic pregnancy occurs when the fertilized egg does not make it to, it has to be fertilized. It does not make it to the uterus. It implants itself somewhere, usually in the fallopian tube. So we end up calling it well, I'm knocking everything over today. We call it a tubal pregnancy if it grows in the fallopian tube, but it can grow anywhere. It can land, it can stay in the abdominal cavity. It can migrate backwards out of the fallopian tube. It can end up at the junction of the fallopian tube and the uterus. It didn't make it to the stratum functionalis. Typically, though, it's going to get stuck for whatever reason in the fallopian tube. So it's a tubal pregnancy, and doesn't happen very often. About 1 to 2% of all pregnancies become an ectopic pregnancy. They say 20 per 1,000. So 1 to 2% doesn't sound like a lot of pregnancies, a lot of cases, but it is, it's, if you're the 20th, if you're in that group, it's a concern to you. The problem here is that an ectopic pregnancy will kill your patient because the baby will grow in utero and will grow and grow, and the fallopian tube, the uterine tube will stretch and then it will rupture. And what's happening though is as the baby is growing in utero, in the fallopian, not in the uterus, growing in the fallopian tube, it's drawing in a blood supply. Our bodies will generate blood vessels. We call it angiogenesis. We will create blood vessels to supply a need. Cancer cells do that all the time. As we increase muscle mass, we generate new blood vessels for that. As we gain weight, we generate new blood vessels for that. As we grow and we hit puberty, we generate new blood vessels. Here we have a baby developing inside the fallopian tube, and so we have an increased blood supply going there. And when that tube ruptures, when the baby has gotten too big, somewhere in that first 3 months, then those blood vessels rupture too, and the mother bleeds out. And it is, as we say, as I highlighted there, it is still the leading cause of death in the first trimester of the pregnancy. So, because it doesn't have anywhere to go. Ectopic pregnancies, where do we get them? We see that they can land anywhere. They can grow in the ovary, they can grow in the fimbriae, they can grow in the ampulla. Most of them are going to be in the ampulla. 78% are in the ampulla. Some can be in the isthmus. Some can be at where the isthmus and the fallopian tube join. Some can be stuck on scar from a cesarean section. Some can grow in the abdominal cavity. They can grow anywhere in here. Some can grow in the cervix. The success rate of bringing a cervical, an ectopic pregnancy to term is something in the neighborhood of 1 out of every 10,000. And it has to be in the right location where it's not going to, it's not going to rupture something. Perhaps at the cesarean scar region, perhaps at the cervix. perhaps at the top of the uterus itself. But if it's going to grow in the uterine tube, it nearly always ends badly in here because when it ruptures, it will the mother will bleed out very quickly. So, but again, there are some studies that show the success rate is very, very low, but it is possible. Something that 1 out of every 10,000 ectopic pregnancies may come to term. It has to, it will have to be a cesarean delivery because if it's not going to be in the uterus, it can't get out. So this is what happens. Ectopic pregnancy, the secondary oocyte gets fertilized and it implants itself somewhere in the uterine tube, usually in the ampulla. It's the area becomes engorged with blood because of the increased blood supply needed. And when that ruptures, then the mother bleeds out and bleeds out very, very quickly. So, and here is what we see. There is the immature fetus in the uterine tube. Here, the tube is getting larger and larger. There's the uterus there. Over here is an ovary. Here is a uterine tube on each side. And there is a developing baby inside this sac, which is the stretched uterine tube, which is sort of what you're seeing over here. And when that ruptures, all those blood vessels supplying this are going to go with it. So now this is pelvic inflammatory disease. Should have said that at the top. This is pelvic inflammatory disease. Pelvic inflammatory disease occurs when we get an infection going on inside the uterus. Now, this can be through STDs entering the uterus. It can be from something that irritates the lining. There is a birth control device, the IUD, I almost said IED, the IUD, the intrauterine device, which is placed in the uterus to irritate the lining gradually so that even if fertilization is successful, the lining of the uterus, the endometrial lining, is irritated enough that implantation can't occur. Well, there are lots of documented cases where certain types of IUDs irritated the lining so much that it became inflamed and infected. So what happens is you can see with inflammatory disease here, the infection will spread and you'll get scar tissue growing over top of the ovaries or over top of the uterus. A good example of that would be at the bottom left-hand corner here of the scar tissue overgrowing the regions simply because something caused an infection to occur or inflammation to occur in the uterus. Now, there are numerous sexually transmitted diseases that can do this, that cause excess growth. Chlamydia and gonorrhea are two good examples. It also can be from some sort of device implanted in there. So how do we treat different conditions with that affect the uterus? Well, there are sometimes the only thing that can be done is to have the uterus removed, and the procedure is called a hysterectomy. And there's a variety of hysterectomies that can occur. A total hysterectomy goes from the cervix upward and takes out the complete uterus. It leaves the ovaries intact, leaves the fallopian tubes intact. A partial hysterectomy is above the cervix and just takes out the actual uterus itself. And then a radical hysterectomy takes out everything cervix and above, including the fallopian tubes and the ovaries. So you have three different things, three different approaches here that are options, depending on what kind of condition you're dealing with. All three of these are fairly extreme procedures. but in some cases there may not be many options to, in what you're dealing with. So, of course, the ideal arrangement would be where you leave the ovaries intact, because particularly if you're dealing with someone who is fertile and is going to would normally not hit menopause for another 20 or 30 years, you would want to have the ovaries intact so that they can continue to release estrogen and progesterone. And because the estrogen, of course, is what helps to stimulate osteoblast activity in the bones so that bones don't get weaker, because if you take out the ovaries, if you have a 20-year-old patient and you remove the ovaries, they're likely going to have issues with osteoporosis later in life, or they'll have to go on hormone replacement therapy. Okay. Now here's we talked about the prolapsed uterus. Here's the tipped uterus. The uterus, because it is held in place by these ligaments, can assume any shape it feels like. Here we see in figure 1, the uterus can bend forward and put pressure on the urinary bladder, which would probably be, at the very best, it would be uncomfortable. It would likely be painful there too. The second occurrence that you see is if the uterus is tilted backwards. That's going to lead to a prolapse where it slides through. Sometimes the uterus may end up pushing its cervix up against the wall of the rectum. And the most bizarre one is if you look at number 4, where the uterus is actually bent in half, and so it is no longer leaning forward over top of the urinary bladder. It is tilted backwards towards the rectum, but it's also essentially bent in half. All of these have got to be extremely uncomfortable to the point of being painful. Okay, leading on from here, we go into the vagina. The vagina is a tube. It's about 4 inches in length. It is the birth canal. It is the passageway for menstrual flow, and it is the organ that receives the penis during intercourse or copulation, as they say. It goes from the cervix to the vaginal orifice, so it opens the reproductive structures to the outside. Everything that means that all these structures are going to end up being lined with epithelial cells because they're open to the outside. The urethra runs parallel, because if you remember, the uterus is tilted forward over top of the bladder. The vagina comes out from the urethra into the vaginal orifice, and directly above that is the urethral orifice, so that the urethral orifice is in an anterior position. It's above the opening of the vagina in the vaginal, in the area of the what we call the vestibule. So, the vagina has a series of folds in here. Here we're seeing the vagina is on the left of this photo, and the cervix is on the right. You can see the cervical canal, and you can see the fornix, that's infolds on either side there. And we have these series of folds that we call invaginations. And of course, the question is, what came first, the term invagination or the vagina? It doesn't really matter, but that's what the folds are called, the invaginations. So, and those folds are often where sperm cells get stuck, because sperm cells can only swim forward. And they will often they'll swim forward. They don't know how to back up. And so if they'll hit something, if they'll bounce off of it, they may keep bouncing until they get to the opening of the cervix, but many of them will get stuck in these folds here. Anyway, within the vagina, if you have an adult female, the mucus secretions that she's going to release in the vagina are going to be acidic. which is going to be, it creates what we call a hostile environment for sperm cells because it's hot. It's hotter than body temperature inside here. It's a warm environment. It's above 98.6 or 37 degrees C. It is acidic. Sperm cells don't like higher temperatures. Sperm cells have to try and neutralize the acidic nature of the adult vagina by having semen that is alkaline. The prepubescent female, meaning she hasn't hit puberty yet or she's going through puberty, her secretions may be alkaline in nature. Now, the mucous membrane around the vaginal orifice forms an incomplete covering of the vagina. We call it the hymen. The hymen has a smaller opening in it. It is not a complete covering of the vaginal orifice. Many cultures believe that a female has never had intercourse or is a virgin if the hymen is not ruptured. Now, the problem with that kind of thinking is that yes, the hymen will rupture during intercourse if the female has never had sex before. Then yes, the hymen will rupture. However, the hymen, because it is just mucous membrane, will be torn by many things: bicycle riding, swimming, running, exercise, rock climbing, horseback riding, gymnastics, competitive sports. All these things can damage the hymen and no one will know. The hymen as a definer of whether or not your female patient has engaged in sexual intercourse, the hymen is not a very good definer of that, because it is thin tissue, it tears easily, So the definition of whether or not a female is a virgin based on the hymen was probably developed long before other activities, physical activities would tear that. And who knows? But the point is, it is not, an intact hymen is not a good determination of whether or not the female's ever engaged in intercourse. Okay. Now, the external genitalia is called the vulva. It is the area that is visible on the outside of the female reproductive structures. First thing we see is a bulge called the mons pubis, which sits directly above the pubic bone. There's a layer of fat underneath there, and there is a lot of pubic hair growing at the mons pubis. Then surrounding the vulva, you have what are called the labia major. They're large folds of skin. It is analogous to the scrotum. It is the outer fold of skin there. It forms the outer covering of the vulva. Then within the labia major, you have the labia minor. And within the labia minor, you have the vestibule itself, and you're going to have numerous openings for mucus glands to release, to lubricate this area. These glands are called the greater vestibular glands. Now, inside the vestibule, at the anterior end of the vestibule, you're going to have the clitoris or clitoris. You're going to have it at the very anterior end where the labia minor come together. It has structures very similar to the head of the penis. It has a glans, which is the most sensitive portion of it. Again, its counterpart is the glans of the penis, about 10,000 times more sensitive to touch than any other part of the female body, just like the glans of the penis is 10,000 times more sensitive in the male. And then there's going to be called the prepuce, just like the foreskin of the penis. You're going to have a small foreskin that covers the clitoris itself. It tends to cover the glands proper, and is analogous to the penis, all these structures here. And then underneath, below the vestibule, you have an area called the perineum. It is the area between the coccyx, the tailbone, and the pubic arch. And we have the ischial tuberosities, if you remember your bone anatomy, on either side. So let's take a look at this. This is the vulva. And you can see with our vulva, at the very top of the vulva, in the anterior region of the vulva where the labia minor come together, we have the clitoris with the prepuce covering the glans itself. And then below that, we have the labia minor, because the clitoris clitoris shows up where the labia minor come together. So the labia minor is slightly below that. Then you have the urethral opening. And then towards the bottom of the vulva, you're going to, on the posterior end of it, you're going to have the vaginal orifice in here. And then below that, we have the opening for the anus. You have the anal opening. And so this is part of what I was talking about earlier about urinary tract infections. You have these three openings in very close proximity to one another: the urethral opening, the vaginal opening, and the anal opening, and in a very confined space that's warm, that's dark, it's moist, it's a breeding ground for bacteria. And it's usually going to be some sort of urinary tract infection that occurs, and the female urethra is only about 5 centimeters in length. So it's very easy for a bacteria to migrate up into the bladder. It's not enough time for the immune system to kick in and stop these bacteria. Males tend not to have urinary tract infections. Males can still have them, but the urethra in a male is about 20 to 25 centimeters long. It gives more time for the immune system to become operative. And of course, the urethral orifice in males is much further away from the anal opening. Anyway, this is what we see here. Now, the structure of the clitoris is on the right-hand side there. You see the prepuce and the glans. The glans is covered by the prepuce. This is, again, the most sensitive portion of the female anatomy. Okay, so here we see this area highlighted here in this sort of triangular shape structure. It is referred to as the, where's the label for it? This is generally relating to the perineum, but here's the clitoris here, the prepuce here, the urethral orifice here. There is the hymen right here, and it says it's ruptured because it's enlarged. This is the vaginal orifice right here in the middle, and we see these vestibular glands on either side of it there, and of course down here is the anus. So this is the mons pubis on top here. This is the mons pubis, is that fatty deposit underneath the skin, and this is where pubic hair, the pattern is different in females versus males. The pubic hair tends to grow more in the mons pubis. Male pubic hair has a different distribution. Okay. Other external genitalia, the mammary glands. They are nothing more than modified sweat glands. They are part of the skin. Males and females both have mammary glands. The mammary glands in males are usually non-functional. We don't know why males have mammary glands, but they don't produce milk. They usually, let's put it this way, they usually don't produce milk. Structures that we notice, the areola, the pigmented portion around the nipple, that will generally turn darker during pregnancy in the pregnant female. the areola will turn a very dark brown, even purple. The milk is produced through these lactiferous ducts that drain into sinuses, and then the sinuses open to the nipple. There are about 20 or 25 openings in the nipple itself for milk to come out. Now, prior to milk production, a pregnant female right after delivery will start producing something known as colostrum. Colostrum is not milk. It has lots of vitamin A, lots of proteins, lots of minerals, and many, many antibodies. Now, there are 5 different categories of antibodies, and what's coming out here in the first 2 or 3 days is what's known as the IgA antibodies. After 2 or 3 days of this, then the mammary glands start producing milk. And we'll talk about this different antibodies when we get into the immune system later on. Okay. So the sweat glands, these are modified sweat glands. There are about 25 lobes of sweat glands embedded in the breast. The size of the breast depends on the amount of fat that gets deposited in there. And the sweat glands are arrayed in, like spokes in a wheel all the way around the breast. And so you can see here is the nipple right there. This is a lactiferous duct right there. And we see the sinus that forms where milk is stored is right in the middle here. And all these little lobules that we encounter are where milk production is taking place. And they go around the nipple in like spokes in a wheel all the way around. The breast is held by ligaments, and it sits in the muscle area directly above the ribs. And you can see the intercostal muscles between the ribs there, and it doesn't show the yes, it does. The pectoralis muscle then sits on top of the ribs. So, and this is what this is what it looks like. We have these glands that the ducts and the alveoli form this spoke like structure, and then the milk is collected in the various sinuses, and then there are openings from each sinus going through the nipple. So when the baby sucks on the nipple, the baby will get milk coming from the sinuses, and then production will continue to take place back here in these lobule areas where we have these structures known as the alveoli. A female that does not nurse after pregnancy, that can't nurse, that can't produce milk, the alveoli don't function. They did not develop properly. If they do function properly, then the alveoli will produce milk. It will go into the lactiferous ducts, into the sinuses, and then pass out through the duct itself. And these alveoli look like this over here. Individual cells, all producing milk. You can see the ligaments holding the breast to the pectoralis major. I like this one in blue. It shows you how these lobules are arrayed around the area of the nipple, and also down here on this one. So what happens in the breast? Well, people develop breast cancer. It isn't just females. Males develop breast cancer too, but the rate is very low, but it still happens. The statistics are scary. Invasive breast cancer is the most common malignancy in females in the US. It is the second most common cause of cancer death in the US. 13% of women will develop breast cancer. Somewhere in the neighborhood of 1 in 8, I think is the number. Breast cancers typically come from the duct, the lactiferous duct. We call it a ductal, an in situ, meaning in place ductal cancer. And then given enough time, it will eventually metastasize and spread. In many cases, the breast cancer is a very slow grower. And that's a good thing. It takes its time. You know, just like prostate cancer can be a very slow grower. Some can be aggressive and grow very quickly. So who's at risk? Well, it's hard to say. The person who starts menstruating early and has a late menopause, you know, that they have menopause late in life, no pregnancies, or a pregnancy later in life, like a 40-year-old female is at greater risk, statistically at greater risk. Okay, no breastfeeding, you know, maybe at greater risk. Is there a familial history of breast cancer? Are they genetically predisposed to breast cancer? Maybe. You know, we've said that cancer doesn't run in the family. Breast cancer occurs because there's a genetic predisposition in that family to breast cancer. The tumor suppressor gene that prevents breast cancer fails early, but not every female or male is going to have their tumor suppressor gene fail. Some do and some don't. We don't know why some do and some don't. You know, just because your cousin and your sister and your grandma and your aunt and crazy Uncle Fred all got breast cancer doesn't necessarily mean that you're going to get it, you know. So I haven't dragged crazy Uncle Fred out for a while yet. So anyway, but it's not impossible for males. Very low occurrence. But remember, we're talking about same structures. The male breast just doesn't produce milk, but it still has ducts. It's still derived from sweat glands. So the most common type of breast cancer comes from these ducts, these lactiferous ducts. Who's at risk? Well, this breaks it down a little better for us. Mutations to the BRCA1 and 2, but here's the kicker. 70% of women with breast cancer have no known risk factors. You could hit every number, every check mark for every risk factor and never have breast cancer. You could have everything, you could be doing everything right. You have none of the risk factors and still get breast cancer. We don't know why it happens. We look at the breakout here. The mutation of those genes, the BRCA1 and 2, they seem to be an indicator that you're at greater risk. You know, so, but then again, you know, remember that 70% of all breast cancer cases have no risk factors. So anyway, the breakout is about a risk factor of the general population of 1 out of every 8 women will develop breast cancer. So that BRCA1 and BRCA2 only cover 10% of the population. So, okay. Types of breast cancer: ductal carcinoma in situ. The cells start growing, the cancer cells start growing in the cells that form the ducts. The cancer stays inside the milk duct. Slow grower. The most common type of breast cancer is the invasive ductal carcinoma. It starts in the duct and then spreads to the breast tissue. The other one, the ductal carcinoma in situ, doesn't spread. It is non-invasive. So unfortunately, it's not a very common type. Lobular carcinoma, this starts in the milk glands. Not a very common type either. And then inflammatory breast cancer, very rare. It makes the outside of the breast look inflamed and inflamed and infected. It may actually make the outside of the breast look like the surface of an orange. It's like all the orange skin of an orange is pitted, and that's what the skin of the breast looks like. So, okay, this is invasive breast cancer right here. Now, so you'll notice that there's a lot of swelling here in the axillary lymph nodes over here. The thing, for whatever reason, half of all breast cancers occur in the upper outside quadrants, the areas closest to the axillary lymph nodes. But the cancers are usually the primary lesions. You don't get cancer in a lymph node and have it, well, you usually don't get breast cancer in the lymph nodes and have it spread to the breast. It usually goes the other way. It usually goes from the breast into the lymph nodes. Now, this is probably the in situ invasive breast cancer. Because of the swelling in the lymph nodes, it has probably metastasized from the breast into the lymph nodes itself. This is inflammatory breast cancer. This is a very unusual type. We see all these lesions on the surface of the breast. We see lesions up in the axillary region. It's likely very painful too. But again, there's no tumor. There's no central mass of cancer here. It tends to grow in the surface of the skin. So where does it grow? Well, primarily on the upper outside quadrant, where it's 50%, and around the nipple area in the areola region too, probably because of the presence of all the ducts coming in there too. But there's no explanation for half of all cancers coming from the outside quadrant. What is, that's the area closest to the axillary lymph nodes. What is going on there that is the trigger? We don't know. There was a number of years ago, it was thought that the use of aluminum salts might have had some sort of causal relationship. If you use an antiperspirant, they're based on aluminum salts, and when you use the antiperspirant, what it does is it plugs the ducts of the pores that are going to, the exocrine glands that release, the exocrine sweat glands that release water under your armpit. And so we put antiperspirant on, and that plugs those pores, and we don't sweat, and we don't stink because we don't sweat. It's the bacteria that live in our bodies that eat that sweat that creates odor. It's their fecal matter that bacteria are releasing. So didn't know it was so complicated, did you? So, but that's why we stink if we sweat a lot. So anyway, it was thought that the aluminum salts may have had something to do with it because it's right there at the axillary region, and half of all cancers are right beside that. No, it's not that. So we don't know why half of all cancers occur in the upper outside quadrant. So how do you protect? How do you tell your patients to protect? Self-examination is the first line of defense. Palpate the breast every month. Palpate the area around the nipple, feel for a lump. Look at changes, look for redness, look for swelling, look for dimpling, pitting on the surface of the skin. Look for any kind of secretions from the nipple. The most common test is the palpation every month what is it, channel 10 does, the buddy check 10 thing. And so, and yeah, but some cancers are sneaky. Some cancers will not be there 1 month and show up the next month. You know, I had a very good friend who palpated her breasts in November and had nothing. And in December, she had a tumor the size of a quarter. You know, and it, how did that happen? You know, because these tumors are usually slow growers, but cancer doesn't play by the rules. So your patients have to examine themselves frequently. Now, the gold standard for testing is a mammogram. With a mammogram is a well-defined X-ray of the breast that can detect tumors the size of the head of a pin. You know, the best that you can feel when you palpate or your patients palpate is something about the size of a BB. You know, in lab, when I had the breast model over there with the tumors in there, it was very hard to detect that, you know. So, and we're talking, you know, usually, you know, a BB is about as small as is the smallest that we could possibly detect. So, okay, so how does the mammogram work? Well, it's a very sophisticated X-ray device. The breast is placed on a glass plate. You lean forward, and then it's pushed down so it's flat. It's flattened on this plate. Because normally, you know, you're not going to get, you know, to get a full picture of the breast, it's not going to cooperate unless there's pressure put on it. See, here we see the normal breast on the left-hand side. Here we see the cancer. We see something growing on the right-hand side. Now, it says it's a malignancy. Well, it's probably because they determined what it was. However, there's lots of things that cause a spot like that to occur. It may be calcification. It may be connective tissue. It could be fibers. It could be anything. It doesn't have to be a malignancy. And this picture here is probably the most staged picture I've ever seen, because if you look at the, you know, you can see that the breast is on the X-ray screen, or where they're going to take the picture. And that device that the technician is pressing on needs to press that breast down flat as it can be on the base. Now, because if they try to take this kind of picture, take an image like this, they're not going to get everything. Now you can imagine dealing with patients who have large breasts, who have small breasts, who have no breasts, trying to get an image like that. So it works, but it becomes more challenging depending on your patient. So here's what a normal healthy breast looks like. You can get all the way into the lymph nodes of the axillary region. You know, they are normal looking lymph nodes. These are the axillary lymph nodes in this area under the armpit in the axillary region. They look like they're supposed to look. And there's nothing growing inside the breast. Now let's take a look at this next one. Here we see the lymph nodes. First of all, they're abnormal because they're large. They're not supposed to be that big. Second of all, we see something growing at the number 3 spot there. And it is like, because of the enlarged lymph nodes, it's likely a cancer. Now, the only way you can tell for certain now is to do a biopsy of the tissue. You can't tell by looking at it. You can suspect, but you got to get a tissue sample out of the tumor, or out of this mass, to see what it is. So, oh, I didn't do that. Don't do that. Let's go back. Come on. Oh, well, it's 12:30. This is a good time to stop, you know. Oh, wait, let's see. Oh, there we go. Some more mammograms right there. You can see the spots, the potential lumps that are there. Here we see a PET scan of the left breast. You can also see that the tumor is in the left breast, but it has also spread. It has, you'll notice there's some spots glowing here and up in the axil. These are the axillary lymph nodes and the cervical lymph nodes. There's some suspicious spots there where it has metastasized. So and we'll pick up with the biopsy then on Wednesday. Lab this afternoon, we're going to take a look at the heart. We're going to have the heart models to look at. Next, yes, ma'am.
So for the PowerPoint, I was looking for it earlier, and you learned is it under Unit 1 or is it under Unit 2? Because I asked because at the very end of Unit 1 in the lab portion of the class, it just shows blood. Is the heart stuff in the blood one or is
No, the heart is in Unit 2.
Unit 2? Okay.
Yeah.
That's what I thought.
And so we're going to look at the model of the heart this week and go through all the parts next week. And I encourage anybody that's on Zoom to come in because we're going to be dissecting fresh cow hearts. So right now, with only the 3 of you in here, we'll have lots of hearts to play with. So
they don't come in more for us.
Exactly. So I would encourage anybody that wants to come in and slice up a fresh cow heart to come in. So